Hi, good evening, everyone. Good evening and welcome to this very important CME today. And I welcome Dr. Amit Mistry and Dr. Mahesh for this. Dr. Mahesh joined?
I think he has not joined yet.
Hello? Dr. Mahesh is there?
He is not joined yet.
Oh, acha. So first, Dr. Amit Mistry will be presenting his speech. Just a minute. Actually, I have bad viral. So just a minute. So I invite our today's speaker is Dr. Amit Mistry. He is associate director, pediatric cardiology. Can you hear me, Dr. Amit?
Yes, ma'am, I can hear you clearly.
Okay. So Dr. Amit Mistry is associate director, pediatric cardiology, Medanta, the Medicity, Gurugram. So I invite him and to start his presentation on aorto-pulmonary shunt. Please continue, Dr. Amit.
Thank you, Dr. Smita. First of all, my sincere thanks to Indian Academy of Echocardiography for giving me this opportunity. In the ongoing series of webinars, I'm been asked to speak about aorto-pulmonary shunts. So just a brief definition about what a shunt is. Anything that provides an alternative path to flow apart from its natural route that the flow is supposed to take is called a shunt. And keeping this definition in mind, an aorto-pulmonary shunt is any communication that exists between either the aorta or any one of its branches and the main pulmonary artery or any of its branches. So normally the blood has to pass from pulmonary artery and then to the pulmonary vein and LA, LV and aorta, and then this circuit continues. But if there is a bypass happening in
Dr.
this
Amit,
circuit,
I'm not hearing you well. So just be little loud. I think it will be better.
so if there is any communication that is bypassing this route, that is called an aorto-pulmonary shunt. We will start with an interesting case. This was an 18-year-old male from Iraq who actually had symptoms of exertional breathlessness and palpitations. And he was being followed up at Iraq as a case of moderate aortic regurgitation. And he was being medically managed with some diuretics and AC inhibitors. As his symptoms had increased over a period of time, he was referred to us for the aortic valve replacement. When we saw the patient, we found that he had a heart rate of 90 beats per minute with a blood pressure of 130/54, a saturation of 96% on room air, with bounding pulses, an LV apex, diastolic murmur of AR, and an MDM at apex. Everything was fitting the bill, except until we did an echo. On the apical 5-chamber view, what we saw was that the LV was dilated, but the aortic regurgitation did not look severe. And secondly, the LA was also dilated as well as the LV, which was not proportional to the LA dilatation was not proportional to the severity of the AR. And when we, as a pediatric cardiologist, saw the abdominal aorta, we saw significant flow reversal in the abdominal aorta, which was not corresponding to the amount of AR that we were seeing on the 5-chamber view. So further interrogating the patient, what we saw was there was a 2D communication gap between the aorta and the pulmonary artery in the peristernal short axis view. And on the color flow, there was a significant shunt between the aorta and the pulmonary artery, suggesting that there was some communication between the aorta and the pulmonary artery, being an aorto-pulmonary window. Now, why this could have been missed? Firstly, the child was 18 years of age, and AP windows mostly by this time become inoperable. So their clinical findings are quite different from what this patient was having as clinical parameters. Secondly, 2 lesions in the same patient and 1 lesion was undermining the other. And third cause would have been probably because of the similar symptomatology and signs for both lesions. So there was quite an overlap between the symptoms and the signs, but there was a mismatch on the echocardiography. So what are the important points from this case? What we learn is that symptoms and signs in this case were not proportional to echo assessment of aortic regurgitation. He had all the signs of peripheral runoff and all that. But if you saw the AR on the echocardiogram in 5-chamber view, that was not looking to be severe. So this tells us that we should expect the unexpected. Because he was 18 years old, an AP window presenting like this at 18 years is relatively an exception. And so exceptions can always occur. And thirdly, one should keep a bird's eye view while performing especially pediatric echocardiography, and a tubular vision of any such lesions may lead to an missing of lesions. And this was confirmed by a CT and an angiogram where you see the catheter coming from the descending aorta in the arch and then through the AP window passing into the left pulmonary artery. And when you did an angio-aortogram, you could see the filling of the pulmonary arteries from the ascending aorta, suggesting that this is an AP window. Similar situation, aorto-pulmonary shunts can also occur. Similar confusing findings are more frequent in truncus arteriosus because the truncal valve usually has an organic abnormality in such cases. It could be either bicuspid or quadricuspid, thereby leading more frequent truncal regurgitation. But the differentiating feature is that you only have one semilunar valve in truncus, while you have 2 semilunar valves, the aortic and the pulmonary semilunar valve in an AP window. So you should differentiate between the truncus and the AP window by the presence of an additional semilunar valve, which is the pulmonary valve. If you see in this echocardiography, you almost have a defect here. You actually have a defect here between the aorta and the pulmonary artery, looking like an AP window in the parasternal long axis view. And if you see from the subcostal view, a similar defect between the aorta and the pulmonary artery, looking like an AP window. But if you further investigate in all other views, you will not find the other semilunar valve, thereby suggesting that this is a truncus as opposed to an AP window. Now, the second aortopulmonary shunt I'll be talking about, I'll be presenting some cases, patent ductus arteriosus, which is the most common aortopulmonary shunt we see day in and day out. And I believe that a relation of a neonatologist to PDA is almost similar to his or her relation with the spouse. And why do I say that? Because both its absence as well as its presence are felt depending upon the timing. So if you have an absent PDA during fetal life, it is almost a death sentence, while its presence in a preemie after delivery is a headache for the neonatologist. But even after delivery, its presence in neonate can prove to be both a boon or a bane, and I'll discuss it in my case presentations. And it can be an irritating structure in premature, while it can turn out to be a lifeline in certain congenital heart defects. Now, PDA as a bane, we had a neonatologist who called me for a premature who was weighing 1.1 kg, high oxygen requirement, symptoms of gut and cerebral steal. Definitely, the neonatologist wants to get rid of it. But using the medications, he risks a GI bleed and a renal shutdown. So you don't know what to do exactly in such situations. And this was the echo of the neonate, whereby you see a large PDA communicating between the pulmonary artery and the aorta. And if you see the same in color, a continuous, unrestricted, non-restrictive flow from the aorta into the pulmonary artery, which was causing the cerebral steal as well as the GI steal. And if you put an M mode across this PDA, you will see a continuous left to right shunt, suggesting that the PA pressure have dropped and now the patient will definitely land into LV failure. So in such cases, the pediatric neonatologist definitely wants to get rid of this kind of a PDA in a preemies especially. But on the other hand, the same PDA can turn out to be a boon, whereby you have a systemic duct-dependent circulation. We had a full-term neonate in a nursery who was delivered by normal delivery, was doing absolutely normal with a saturation of right upper limb of 97%, feeding well, and was discharged. But he landed in emergency on the third day of delivery with feeble pulses, acidotic. I was called in the nursery for the same patient because of the situation. And when I started doing the echo, I could see that the RA and RV are grossly dilated. There was a VSD which was shunting right to left, and there was biventricular dysfunction seen. The patient was on ventilator, so grossly sick baby. And when I did the suprasternal view, you could see the ascending aorta and the arch up to this normal, but then there is a sudden tapering of the arch beyond the subclavian, and there is a flow from the PDA to the lower end. I will show you it in the color mode. You can see the very streaky flow from the PDA shunting right to left, and absolutely almost an interruption of the arch at the same level. So because the PDA was getting restricted, which was actually the lifeline for this baby, the baby was becoming sick. So immediately a prostaglandin infusion was started. And now you can see the PDA has opened well and wide, and you have now a bidirectional shunt, and this PDA is now supplying to the lower part of the body, while the upper ascending, while the arch is still restricted, almost like a critical quacked or an interruption. But you have got plenty of time to shift the baby to a surgical unit and get the arch repaired. So in this kind of a situation, the PD has actually acted as a boon for the baby, and the neonatologist definitely wants it to be here till the time the baby is shifted. Similarly, this was a left, right to left shunt, but you can have duct-dependent pulmonary circulations, whereby a full-term newborn weighing 2.8 kg, day one doing well, shifted to mother side. During night, mother complained that baby was not looking well, not accepting feeds and irritable. So he was shifted back to nursery. But this time the finding was that the saturation had significantly dropped to 64%. And again, I was called for what was happening. And when I did an echo, you can see that there is a VSD and there is filling of the aorta, but there is no antegrade flow from the ventricles to the pulmonary artery. And there is some streaky flow into these pulmonary arteries from most probably a PDA. And when I did the suprasternal view, you could see the PDA filling the pulmonary arteries, but getting closed. At the time of birth, the PDA would have been large, so he was not symptomatic at that time. But over a period of time, the PDA started restricting, and so the only source of supply to the pulmonary artery was getting obstructed, and the baby was becoming desaturated and sick. So in this case, the baby was shifted to our hospital, cath lab, and then a PDA stenting was done across the PDA. And then after the stenting, you can see very well the filling of the pulmonary arteries, and you can see the stent. So you have bought enough time and salvaged the baby from a gross critical state. So in this situation also, the PDA has acted almost like a boon for the survival of this patient. In such situations, one can also, along with starting the prostaglandin infusion, go for the surgical BT shunt, whereby you can see the echo in which you see a communication being established surgically between the innominate artery and the pulmonary artery. And then you don't depend upon the PDA as such for further supply to the pulmonary arteries, because you have established an alternate path of supply to the pulmonary arteries. So types of aortopulmonary shunts can be either natural, the most common being the PDA, but you can also have an AP window, a truncus, and MAPCAs, the major aortopulmonary collaterals, while you can also have acquired aortopulmonary shunts in the form of most commonly BT shunt, or keeping the PDA open by using PDA stents. This is the last case I am presenting, an interesting case of aortopulmonary shunt. This was a 15-year-old female from Srinagar. She had recurrent episodes of cough with hemoptysis for last 3 months. She was evaluated at various hospitals in and around Srinagar, mostly by pulmonologists because of the hemoptysis, and was put on anti-tubercular treatment. The outside echo, which was done at Srinagar, was normal, so no cardiac abnormality was suspected as such. But she was referred to us for the hemoptysis part. Actually, she was referred here also to the pulmonology section, but they further gave a call for us. And our findings were that the BP was around about 124/62. There was no cyanosis. Structurally, the heart looked normal, but there were some unusual findings. The LA-LB was dilated, and no reason was found for that. And there was some flow reversal in the descending aorta. And this was, I don't have the echo, and I am apologize for not having the echo images of the patient, because this was in 2018 during the COVID time. And this was the X-ray of the patient, which was suggesting that the right lung is normal, but there is some haziness of the left lung if you see the left upper lobe and all that. So we sent the patient did to the cath lab and did an aortogram, whereby we found that there were multiple serpentinous aortopulmonary collaterals. You can see them filling almost all parts of the left lung. And even there was a collateral from the left subclavian artery. And so we tried to coil as many as we could. This is the coiling of that, and blockage of the MAPCA with the coils. And this is putting a device into the one large collateral from the left subclavian artery. So we tried blocking as many as possible. The patient definitely did better. Hemoptysis part resolved. I saw the patient 2 months back in Srinagar OPD, and she was doing absolutely fine. So, and on having a review of literature, I could find 4 cases, 2 I have depicted here, whereby isolated major pulmonary collateral arteries causing severe pulmonary hypertension in an infant, a rare diagnosis, and a rare case of hemoptysis in West syndrome, isolated aortopulmonary collaterals in structurally normal heart. So this is a very rare entity which one can come across. So when should one suspect an aortopulmonary shunt on echo? Obviously, if you have a normal heart, but your LA and LB seem to be dilated and you don't have any intracardiac shunt, one should suspect that there may be a shunt beyond the heart. And if you have a descending aorta flow reversal in the absence of a significant aortic regurgitation, one should definitely suspect that there is some shunting at the level of aortopulmonary level. And sometimes when you have MAPCAs, especially in cases of VSD pulmonary atresia, you may have an ipsilateral pulmonary venous return abnormality, whereby you have more of the pulmonary venous return from one-sided lung, but not significant from the other side, because the collaterals may be supplying to one lung predominantly. And in such cases, you have an ipsilateral venous return. So in conclusion, aortopulmonary shunts are not rare, PDA being the most common. Usually they need closure, but may be very important in certain conditions and may act as a bridging therapy in such situations. Certain types of aortopulmonary shunts may be missed if not looked carefully, and therefore clinical and echo correlation becomes very important for diagnosing and recognizing these patients. Thank you.
Very
Excellent, Dr. Amit.
great presentation, Dr. Amit. And actually, for the newcomers or maybe adult side cardiologists, they must actually attend this particular seminar. Very brief, very comprehensive, and almost everything covered. So, as Dr. Manish said that question answer should go at the end after the Dr. Mahesh talk. I welcome Dr. Mahesh and Dr. Vijay
Smita,
Lakshmi, and Dr. Vijay Lakshmi. Please
Smita, what happens
take
is
over.
if we keep at the end, we miss. So soon after each presentation, if we discuss, it's better.
Oh, ma'am, that
Okay.
was instruction to me. So whatever you say, yeah.
Okay. Amit, that was a great presentation with really excellent cases. And what you said, PDA can be boon or bane, that's also right. And last one, you said that either they have to be, mostly closed, sometimes they have to keep them open. So both the statements are real good statements, and the youngster should learn from that. In fact, Helen Tossig, when she went to Mayo Clinic to meet Gross and then ask for the BT shunt, he refused. He said, "Look here, lady, I'm here to close the PDA, not to create one." But today we have realized that a presence of PDA, especially duct-dependent cases, and you showed a great case of stenting also. And in fact, echo, under the echo only, the premature babies having the closure was first done by Neil Wilson. And it was really, remarkable that time. Even 800,000 grams they were doing at the bedside without even a cath lab in the ICU itself,
Yes, yes.
NICU. And I have to mention one to the youngsters. See, most of the neonates are not sent to us to do the echo. And they see that the patient is all right, saturation is all right, they discharge. And as you mentioned, the PDA closes and they start becoming worse. And ultimately, in one of my cases, it was a TGA, duct dependent, and then it became worse on the third day. And by the time we made diagnosis and immediately sent for surgery, but still it was difficult. And then the parents put a case against the pediatrician. So the neonatologists and the pediatricians also should join and have a basic echo thing. And this was really a great one. And the last case that you presented, aortopulmonary collaterals, I have not seen in the thing, what to say, normal structural heart. That's a extremely rare case. But then, this aortopulmonary collaterals in cyanotics, especially in the tricuspid atresia, I have seen post-operatively they don't close, and that time they come with hemoptysis and hypertension. So that time we have to close. And other one is the AV fistula, pulmonary AV fistula, invariably normal structural heart, and people miss it. And I think a good X-ray and the good clinical acumen can make out. Except that, excellent presentation. All nice
Thank you, ma'am.
cases.
So,
Thank you.
Dr. Amit, one thing I want to actually just highlight, like in a smaller babies, I'm sorry for my throat. I'm having very bad viral. So, if you are having absolutely normal aortic valve and having aortic regurgitation, particularly in the smaller babies, probably one has to always look for something else. Would you agree with this statement?
Definitely, ma'am.
Hello.
Definitely. If there is if there is a mismatch between the findings, you definitely have to find an alternative diagnosis to explain your findings.
Right. Okay, and about the pulmonary AV fistula, by chance, I have seen many isolated pulmonary AV fistula. One of them I closed in adult, actually 48 years old, presenting with the hemoptysis and definitely got improved. And the another one was our Dr. Ashutosh had a case where very small this thing collaterals were all over lungs, and it was really nothing to be done in that particular case. So sometimes you get many unusual thing, and
Yeah.
what could be a impetus or what could be the stimulus for this kind of collaterals, I really won't know. In your case, it was a they also treated the patient for the tuberculosis. So was there any cavity or anything, or it was just a presumptive diagnosis
No,
and it
ma'am, that, that
No,
that was a
no.
presumptive diagnosis.
The symptomatic treatment, most of the
uh,
people do that.
okay,
Amit, there is one question by the audience. Can
uh,
agitated saline be used for diagnosis of AP shunt, aortopulmonary collaterals? They are meaning. No, that is only for
Ma'am,
the AV fistula, not for the aortopulmonary collaterals. Yeah,
you can use a contrast study for an aortopulmonary shunt only in cases where there is an Eisenmengerization of the shunt. When you have a right to left shunt, in
it will
such
not work.
cases, if you do a contrast study, you may find some bubbles traveling from the pulmonary artery into the aorta, but the patient in that situation will be cyanotic and has to be Eisenmengerized. So,
Yeah,
but normal aortopulmonary shunts with normal pulmonary vascular resistance, the shunt will be left to right. So you won't
so it's not.
find a contrast in such. The contrast won't be helpful in such cases.
But in AV fistula, it
In
helps,
AV fistulas, the patient will be cyanotic. And when
and
you
they will
do
have the
a contrast, you will find that the contrast, saline contrast bubble coming immediately into the
to the left
LA,
side.
into the LA. So that is one diagnostic test you can do in cases of pulmonary AV fistula, definitely.
I hope it is clear. Aortopulmonary shunts are different from AV fistula. So those are two different ones.
That is why
Okay.
I didn't mention AV fistulas in this situation,
Okay. It's okay.
because it would have confused the audience.
No, no, you have
so
covered
Dr.
everything.
Amit, if a baby with the pulmonary atresia VSD and the multiple MAPCAs, so can they present with the hyperdynamic circulation just like the PDA, large PDA?
Definitely they can present, ma'am. It depends upon how many MAPCAs are there. And most likely, as Dr. Vijayalakshmi ma'am has already told, that they become hyperdynamic after surgery. You have established an antegrade flow and the MAPCAs remain there. And then you have an overloaded LA-LB and they land into
Correct.
left-sided failure, and then you have to treat them. But
Absolutely.
even before, even if you have not done surgery, you see that VSD pulmonary, some of the VSD pulmonary atresia patient may not be so cyanotic because they have huge MAPCAs which supply a great amount to the lungs, and they are relatively less cyanotic, but more into state of left-sided heart failure because of the uh, increased QPQS shunting.
So they will need some decongestive therapy in that case?
Obviously, they will need decongestive therapy, but they will need primary surgical repair, either in the form of establishing an antegrade flow and closing the collaterals, or in some cases where you need a unifocalization along with the establishment of an antegrade flow.
So as you said, Dr. Amit, actually I got a patient 3.5 years old, and it was like mild cyanosis was noticed at this age and was very well followed up from the pediatrician, and cyanosis was apparent only around say 3 years of age. So I kept on thinking patient is coming, probably it's a pulmonary AV fistula and I have to close, and I actually discussed in that way. But really, that patient, when came to me, it was really very interesting. Murmur all over back and the axilla, and it was a pulmonary atresia, no minuscule pulmonary arteries and the multiple MAPCAs. So patient may be really very asymptomatic at times with the MAPCA dependent circulation, but they can they can be a very complex
I know.
situation there could be.
But
So
Yes,
if I
Smita,
can
what you have told is
in-
right, because sometimes,
uh,
the regular duct will not be there. Madam
uh,
Helen Taussig says in pulmonary atresia, since the fetal blood is not going to the ductus, there will not be PDA, but they can have a vertical duct. And that vertical duct, unless they do the suprasternal or high ductal view, most of the people miss that vertical duct. So that has to be kept in mind. Amit, incidentally, I have closed a PDA larger than the aorta. PDA was 8.6 and aorta was 8. And for that, I had to get the angle device custom made by Kurt Amplatz. And he made a custom made device and then we closed that. So that was only a 4.2 kilo, but PDA larger than aorta.
Great. So, Dr. Amit, you were saying something, and probably it may be a last comment, and Dr. Vijay Lakshmi then can introduce Dr. Mahesh, the next speaker.
I was just adding to the case whereby you said that there were large MAPCAs and the patient was relatively asymptomatic and less cyanotic. I think one thing what should be careful in such patients is that such collaterals may over a period of time become maybe hypertensive and then over a period of time become Eisenmenger-ized. So you should definitely do a cardiac cath in such cases and establish what is the PA, what is the collateral pressures, so that if the child has to be operated upon for hypertensive collaterals, that is done early so that the collaterals don't turn up to be Eisenmenger. I think
so
that
in that
is
case, Dr. Rajesh Sharma tackled one very badly sick patient, around say 3-4 months, around 3 months went into ICU, and he did a MAPCA banding. So that really worked for the baby. Their pulmonary arteries were really good size. And then subsequently patient was operated, complete correction done around 1.5 years. So sometimes you get a miraculous escape in that case. Dr. Vijay Lakshmi, ma'am, please introduce our other esteemed guest, Dr. Mahesh. So, hello, Dr. Ma'am, you are muted. Ma'am, please unmute yourself.
Sorry. Dr. Parashar called, so I just closed. Okay. Yeah, but I don't have the introductory slide.
So actually, this is introductory slides were not given to us. Only you have to introduce, and they are big names,
So the big names don't require any introduction.
Mahesh ka naam hi 3D printing ke saath chalta hai.
Mahesh, you can go ahead.
Yeah, let me introduce myself.
Yeah, Mahesh can be heard and seen also very well. So go ahead.
Yeah, so hi everyone. My name is Dr. Mahesh Kapanail. I'm a professor of pediatric cardiology at Amrita Institute of Medical Sciences in Kochi. And my talk here is going to be a little deviating away from core echocardiography because we're going to talk about some 3D technologies. So I'll just start sharing my screen.
So Dr. Mahesh is very talented right from beginning. He is a very sporty person also. And he is really doing unique thing, particularly because he picked up a field which nobody was picking up, and that is the MRI. So he is a authority on 3D printing and MRI.
So right now I'm sitting in what is the virtual reality lab in the Department of Pediatric Cardiology at Amrita. So you might wonder what
screen your PPT.
I'll just share it. I just want the audience to see this particular room where I am in. This is where we do a lot of magic with virtual reality. We use devices such as this. We wear one of these devices and we look at hearts as holograms in front of us as 3D structures using different devices like these. So these all are newer forms of how now we're beginning to visualize and image the heart. And we use these things, which are actually 3D prototypes of the cardiac anatomy. And these prototypes are built with the help of 3D printers, and they are exact replicas of the patient's hearts, and they're created from patient's own tomographic scans. And so as you can see, it's possible today to hold the heart of the patient in our hands today. So when we are in our CAT meetings, in our surgical discussions, when we sit down together to discuss how we're going to operate a particularly complex case, we would have one of these replicas in our hand. And these are exact 1:1 scale replicas of the patient's own anatomy, and we can actually open it up. We can see how it's a DORV, it's the aorta that's coming out from the right ventricle, as well as the pulmonary artery. You can see the ventricular septal defect. You can actually measure the distance from the VSD to the aorta, and you can plan how you would put a patch across to close this kind of a defect. Here, for example, is a newborn heart with a double aortic arch. So when we do an echo or a CT, many a times, especially for the younger colleagues, it'll be very difficult for them to really imagine how a double aortic arch looks like. But here, what I'm having is I have a 1:1 scale replica of the patient's actual heart in my hand. And looking at this, even a first-year fellow who's just joined a week before would get a very clear idea as to what a double aortic arch actually is in terms of the morphology, the size, shape, scale, etc. This becomes particularly important in cases like this. This is a crisscross heart, where there is a crisscross atrioventricular connection. So it's almost as if you caught the atria, caught the ventricles, and twisted it. So your right ventricle has moved superiorly and leftward, and your left ventricle has moved downward and rightward. So these are all very, very complex morphologies, which sometimes can be extremely difficult for us as cardiologists to image and understand. But our decision-making towards our patients depends upon how well we understand. When we understand morphology well, we are able to get better care of the patients. So with that, I will start my presentation. Hopefully, you're all able to see the screen. And okay. So as I am, of course, a doctor like all of you, a pediatric cardiologist. I'm not an engineer, but I have a lot of passion for technology, and I play a lot with technology, especially in the way that it can help us as cardiologists in our field. So some of the challenges in pediatric cardiac care are that we face a very wide spectrum of morphology. And so we need to be really skilled at imaging anatomy. We need to, as cardiologists, we need to understand anatomy very well. We need to understand the correlation between anatomy and physiology. And we are responsible for planning and performing complex procedures, be it in the cath lab or be it in the OTs. But one important thing that sometimes we overlook is the fact that whether we are doing echo, whether we are doing reading a CT, MRI, we have to look at the third dimension, because human biology and pathology obviously occurs in 3 dimensions. And the operating fields are also 3-dimensional. It's not 2-dimensional. Eyes are actually built. We have 2 eyes so that we capture 2 images, which then fuse together in the brain to give us a 3D perspective. But paradoxically, much of the medical imaging is viewed as 2D, even if it is actually volumetric. Like CT, MRI, and 3D echocardiography are all volumetric scans. But even these, we conventionally watch in 2D. It is very different for a surgeon. When the surgeon opens up the chest, he can see the heart in all its 3-dimensional glory. But as cardiologists, when we look at images, mostly we are looking at flat 2D screens or flat images. And we are cutting these slices of information, and we are trying to configure in our own brain as to how it would actually be in the 3-dimensional space. So this is the way that we would conventionally look at even volumetric scans like CTs and MRIs, or 3D echo for that matter, on the screens. Even when we look at volume rendered images, you're looking at those volume rendered images on a flat 2D screen. So you don't get the true sense of scale and depth and spatial perceptions. But with the help of these novel 3D technologies, like I just showed you, it is now possible to bring these 2D images into its true 3-dimensional format and actually hold it in our hands for a very tactile kind of an experience. Or we can use these modern technologies like virtual reality and mixed reality, augmented reality, to handle these same things as digital holograms. These are cases that this is the way that we are now dealing with things here. This is a CT scan of a patient that I'm looking at in an extremely immersive way using virtual reality. So I have on a virtual reality headset, and I'm using these gaming controllers to do virtual dissections and try to understand the complex morphology of a double outlet right ventricle till the time that I really understand it well enough to take clinical decisions. Using these technologies, the experience can be so immersive that it's as if the heart is hanging in space in front of you as a 3-dimensional structure. You can pinch and zoom it, And in this particular room where I'm sitting, we would, just pinch and zoom a heart and make it almost as big as this room. And the entire team would actually take a walk inside. You can see here that I'm actually getting inside of the heart and walking in through the VSD of a complex heart and trying to understand what the structures are. It's a very physical thing. And as I'm doing it, I am actually inside of the heart. So it's no longer looking at a 2D screen, but it's being inside there. So how did we start our journey at Amrita in these 3D technologies? The journey started almost 10 years back. And it is driven by the fact that most of us, even when we trained as cardiologists, we hardly ever got to see morphological specimens. We were taught many textbook descriptions, classifications. We saw diagrams of what each lesion should look like, be it, common AV canals, truncus. We looked at, numerous classifications and figures, even for the surgeons. And we are supposed to understand the three-dimensional anatomy just looking at these and reading the text. And it is very variable as to how much we can understand that or absorb that. So numerous classifications that we have learned by heart. But our 3D understanding depends on two important things. One, if we have seen something, then of course we know it because we have seen it, we've done it. And second is our visual processing skills or the spatial intelligence, which is an extremely variable trait. Like the other aspects of intelligence, like emotional quotient or IQ, EQ. Similarly, the spatial intelligence is very variable and independent of one's experience or other skills. It can be very different. And there are specialized tests by which we can actually measure people's spatial intelligence. And we actually did that experiment. And we measured the spatial intelligence of all the members of our pediatric cardiac unit. And this was a test in which there were 30 objects which needed to be, mentally rotated. And you had to figure out what that object would look like if rotated in a certain manner. This is how we actually figure out cardiac morphology as well, right? So we used this test in our own department, and we found that the scores out of 30 people scored a maximum of 15, and mostly it ranged between anywhere between 0 to 15, and it was very, very variable, independent of whether you're a consultant, whether you are a cardiologist, whether you're a cardiac surgeon, whether you're a fellow or a consultant. So the importance is that if we as physicians are unable to understand and internalize anatomical complexity, it can translate into suboptimal care for our patients because we use our understanding to make major decisions for our patients. And it would not be uncommon for us to sometimes reject very complex patients because we haven't fully understood it. And we think that it is too complex, cannot be fixed, and therefore we might not proceed. And the patient may actually be losing a chance at life. How we got into it was with inspiration that came most unexpectedly from this young boy. This was exactly 10 years back that this 17-year-old boy with a really complex situs inversus dextrocardia VSD-PS came to us. And he had been to many centers and he had been rejected heart surgery at all centers, saying that his heart disease is much too complex and it cannot be fixed. So when I did the MRI here, I could understand that anatomy little better because I spent hours on the MRI and I could sense that, yes, this is fixable. But when we discussed in our CAT meeting, our team was not on the same page and I couldn't get them to really agree to operating this child. And this was the first time that I, sent out this patient's MRI scans. At that time, 3D printing was not available in India, and I collaborated with a team in Belgium, and we got a 3D printed model of his heart from the very same MRI scan. And I represented this case in the CAT meeting. And this time, instead of just looking at these 2D scans, the team actually had the 3D printed model in their hands, and they could look inside the heart, and all the spatial relationships became very clear as to where the VSD was, where the aorta was. And in 5 minutes, a decision which had waited 17 years got taken in just 5 minutes, where the ventriculotomy incision would be done and how the LV can be routed to the aorta. And this boy underwent a corrective heart surgery in the very next few days. And this kid actually turned out to be a brilliant whiz kid himself, who himself was passionate about 3D printing. And today, this boy works with me in my 3D printing lab. He's now going to be a PhD candidate here, developing novel technologies in using 3D printing and virtual reality in congenital heart surgery. This boy has traveled the world with me. He's been to the recently concluded World Congress in the US, prior to that in Barcelona. And we have been keynote speakers at multiple international sessions where we have talked about how technology can help people. So his story really inspired us to set up a 3D printing lab within Amrita itself, because if one Hari could be helped, definitely there were many more patients who were waiting to be helped by technologies like this. This is how we set up the 3D printing lab at Amrita in 2015. This is the 3D printing lab where we have our own set of software where we convert the CT scans, MRI scans, and 3D echo scans into digital 3D files, which can then be converted into physical models. Started off with cardiology, but now many specialties, including craniomaxillofacial, plastic, etc., use the facilities of the 3D printing lab to solve complex morphological problems and do really difficult surgeries. These are the 3D printers in our hospital. And we go end to end from the imaging right through to the creation of the 3D models, everything here. So everything begins with getting a good imaging data set, which could be CT, MRI, or 3D echo. It has to be volumetric scans. These are put into a software, and we do a process called the segmentation, where we segment out our region of interest, convert it into a format that can be read by a 3D printer, and then eventually we have the model in our hand. So this is how the regular scan initially looks like when we look at it in multiplanar imaging. And then we have converted that into, convert that into a 3D model, digital 3D file. As you'll see here, the file has been converted into a digital 3D file out here, right? And once we have the digital 3D file, the next step is to bring it out into a 3D printer. And finally, we have the physical prototype in our hands. Now, this is exact 1:1 scale with the patient's own anatomy. So we know exactly what we're dealing with. This is an LPA sling. You can see how the LPA is slinging around the trachea and causing the tracheal obstruction. Which I saw at about 3 months of age, and the baby had been given up for an irreparable thing in remote part of Kerala. And this was one of the cases where a few years back we brought the child back here. We did a CT imaging. We looked to try to understand the shape and structure of the sternum, the exact nature of the sternal defect, the amount of gap that needed to be bridged, and then we created a digital model of the patient's sternum and physically printed it down. So now we had an exact replica of the patient's thoracic cage in our hands, and we used this not just for communicating with the family, but also sat down with the plastic surgeons, and we made a very elaborate plan of actually creating a perichondral flap to bridge this gap and taking a piece of the patient's own 7th rib, an autologous rib, and putting it as a bridge across to recreate the sternum. This whole process was actually planned using these 3D printed models, and it was practiced several times using the 3D printed models. And finally, the surgery was executed to perfection. And this was the baby's first birthday that the baby celebrated with us. And now she's almost 4 years old and thriving and doing really, really well. And these were all stories which started to inspire us to use it for more and more purposes. So we've used 3D printing as a guide in different procedures, creating patient-specific pulmonary valve implants, using it to strategize for placing of PDA stents in really complex PD anatomies. It's a really tortuous PD, and we really figured out the anatomy in the 3-dimensional space. When we look at echo, it's very difficult to figure out how curvaceous the PDA is, how it's going and inserting. But once we have a model in our hand, we had a very clear perspective as to where we should go, what approach, how and what length, where would we land the stent, etc., etc. So numerous cases started accumulating. Now we've done hundreds of cases of this is of course reserved for only the really complex cases, and we've done hundreds of cases now using these technologies. And each of these models then continues to be a teaching model for morphology, because even after the case gets operated, these models stay with us, and our fellows are able to look at these models and understand what a crisscross heart is or what a double outlet right ventricle is. But going a step further, we thought that why not gamify the visualization even more without physical printouts? Because now kids are, interacting with each other in the virtual space. There's so much talk of metaverse and virtual reality, etc. So we thought that why can't we convert these same digital files into digital holographic images? And so instead of physically printing out an object, what if we convert that into a digital object that we could interact with in almost as if like a real object? this would save us the material, the printing cost, and it's so much more flexible, and you can manipulate these objects digitally. So these are two ways in which we look at 3D, either 3D prototyping, which is 3D printing, and then this is extended reality or so this is the virtual reality lab, how we started out with and so this is the crisscross heart that I was talking about. So we have, when this is a really complex heart and we had a really complex decision making what could be done. And here we used the combination of both virtual and physical models to really get a hold of it. With virtual reality, you have these virtual dissection tools, and we can actually cut through the heart in any plane flexibly, because with a physical model, you do have certain limitations. But with the virtual model, as you can see, you can cut through, do these virtual dissections through any which plane and understand the anatomy really, really clearly so that we can make a really good decision. So this is how I would create a virtual 3D model. I'm using a software to create a virtual 3D model. As you will see, I'm doing this segmentation and I'm wearing this headset as I'm doing this. And as I do, this 3D model actually emerges in front of me like a magician pulling a rabbit out of the hat. As you can see, the 3D model is just emerging in front of me as a hologram right off the surface of my table. And then it would be hanging in space right there for me to visualize. This is I'm using a software to look at another really complex heterotaxy heart with a common AV canal and double outlet right ventricle and ipsilateral drainages of the hepatic veins, ipsilateral drainages of the pulmonary veins, everything in different planes, and it's super complex to really understand, no matter what form of imaging you use. But once we bring it into this kind of an immersive kind of space, you can very clearly try to understand, okay, where are the pulmonary veins coming? Where are the hepatic veins coming? How is the common AV valve orientated? Where are the great arteries? We're doing these virtual dissections. I'm annotating in the free space. So you see those arrows, they're hanging in the three-dimensional space in the air in front of me. So anybody who wears that headset can actually see that exactly where I placed it. In fact, I could do these collaborative sessions where I can invite another person to join the session as an avatar, and the person would be right there with me and seeing the same things. Just looking at a few examples, this is a case with a really complex anatomically corrected malposition of the great arteries from Africa. They'd been to multiple centers across the world, been palliated with a shunt, but then not offered any further surgery because of the complexity of the heart. But when we brought the child here, we did an echo, we did a CT, but then even after that, we were still confused about the anatomy. But here I'm looking at it in the virtual space, clearly understanding how the aorta is coming off from, it was as if the right ventricle had been compartmentalized. It's a very, very unusual anatomy. None of us in our team had ever seen the likes of it before. And not only looking at it from outside, we've gotten inside the heart right now. As you can see, I can see a complex VSD inside. And there is a little tunnel underneath there. That's a muscular tunnel that actually leads up into the aorta. So one is actually taking a walk through the cardiac anatomy to try to understand this. And, basically that interaction in an extremely immersive manner gave us a total insight into what this anatomy is. And then when I handheld my surgeon and walked him through this anatomy, there was crystal clarity as to what the anatomy was and what needed to be done. And the next day, this really complex anomaly, one of the rarest forms, was fixed very, very effectively, and the child is doing tremendously well. So this was another look at how that muscular tunnel underneath, very unusual. We had never seen something like that causes subaortic obstruction. And with the VR, I'm actually crawling into that space underneath the aorta and getting into it. And it's almost like, climbing a cliff that, you physically are crawling up that space. And there I am looking up at the aorta, which is hidden behind that muscular tunnel, and then crawling out of that aorta. You can see the neck vessels coming out from the aorta. Here's another case where it was again a DORV, and you can see that the aorta is completely coming from the right ventricle. And yeah, so I've annotated it in the free space, and then I'm dissecting through the RV free wall. And what was very unusual about this case was that the VSD was in a much deeper plane, and there was a straddle of the mitral valve chordae across into the right ventricle. So these arrows are actually the mitral valve chordae that are traveling through the VST into the right ventricle. And so this was what the anatomy was like. So these chordae were actually traveling across, and being able to dissect it in multiple planes, I'm able to see that very, very clearly. Now, having cut open the heart digitally in another plane, I can very clearly see the orientation. This is the left ventricle. This is the route to the aorta. And so we are looking at the various options that we have. This is a route to the PA. So either you have to route this VST into the aorta, but then there are chordae that are overlying here. Second option was closing the VST like this by overlapping over the chordae and then doing a switch. So these are all strategies which were discussed using this virtual reality. And here I'm using another technique to do for the very same case, looking at it in another way, again doing a virtual dissection. Here again, you'll see the overhanging, the straddling chordae very, very clearly. So these are the chordae that's the VST behind, and these are the mitral valve chordae that are traveling across into the right ventricle, right ventricular aspect of the septum. So these are all virtual dissections. It's almost like doing a morphological dissection, but with the patient being absolutely intact. And here I have labeled the mitral valve and the chordae for even greater clarity, so that when the surgeon sees, he can very clearly see what it is. So here then the strategy was made that we'd place a patch which would actually cover these chordae, and we can place a patch. So here I'm simulating the placement of a patch so that we are involving the chordae into this aspect of the left ventricle, so that we route the LV into the pulmonary artery and do an arterial switch. So this was the surgery which was planned in this case, and again executed very well. Here again is another case of a double outlet right ventricle. Clearly understanding you can clearly see that the VST is entirely subpulmonic. The aorta is further away, but much more anterior, and virtually dissecting it in various planes gives us a very clear idea as to where these anatomical structures are and how they are orientated to each other. Here I'm doing a measurement of the ventricular septal defect, all in the virtual space, precise measurements, and then measuring the length of a patch that it would be if I was to route LV to the aorta. But I can see that there would be conal septum here that would come in the way. Then I can measure the distance between, if we close it like this, there I am doing the measurement of the patch. If I close it, if I close the VST into the pulmonary artery and then do a switch. So in this case too, we routed the VST into the pulmonary artery and then did a switch. This is a case of an arteriopathy syndrome with an extremely dilated, massive aorta, a genetic syndrome which is peculiar to Malabar districts in Kerala. And here I am actually taking the aorta out of the thoracic cage, looking at it, understanding the relationships, understanding how the left lung is completely flattened behind that aorta, and doing virtual dissections through this heart to understand all the spatial relationships very, very clearly before we went in for a surgery, which was actually an aortic replacement. So we replaced the entire ascending aorta. But again, we went in with a great deal of surgical planning. This is a transcatheter pulmonary valve implantation being mimicked and simulated before we went in. This is a Melody valve implantation. So we 3D printed out the heart model to understand the coronaries, the calcium, and then we created a digital model of the Melody valve and digitally implanted it to understand how it would lie and where the landing zones should be. And when we went in for the procedure, we had it all very, very clearly planned and laid out, and we could do the procedure very successfully. This is the case with multiple pulmonary AV malformations, where I'm doing the annotations in the three-dimensional space. The patient had 3 very peculiar AV malformations within the pulmonary artery anatomy, and we very clearly planned all the lengths, the dimensions, the angulations, the catheters to be used, the devices to be used. Everything was very clearly planned. Lastly, we did a PG thesis on this subject here, where we compared how our team performs when we look at cardiac images the conventional way versus when we look at 3D prototypes versus when we look at virtual reality images. And we found that with conventional images, image viewing, the average accuracy of our whole team in interpreting these images was about 60%. And the fellows were particularly bad, and the fellows had, if you look at the leftmost graph, the performance of the fellows was at some 38% was their level of accuracy. But then when we gave them 3D printed models and then virtual reality, you can see that everybody, including the heads of the departments, cardiology, cardiac surgery, everybody's accuracy of interpretation just shot through the roof to reach 90% plus with virtual reality. And look at that, the way that the fellows have improved. The quantum leap was in the understanding of the fellows. The fellows' understanding of complex anatomy became almost equal to that of the senior consultants. So immersive visualization interaction allowed better, deeper, faster, simpler interpretation, and it overcome the traditional barriers and really cut down the learning curves. And the other way in which we use these technologies is also for collaboration. This is me collaborating with somebody from another country where I'm actually showing them the complex anatomy of a case in a collaborative session. We are together there in this session as avatars, and I'm explaining the anatomy to the other person as an avatar. The person is sitting in Canada, of all places, and I'm sitting here in Kochi, and still we are able to interact and understand together. And this is using the Microsoft HoloLens. Yet again, I'm showing a collaborator a 3D echo image and an X-ray image and a 3D CT image. The lab reports, everything hanging in space. This literally in my drawing rooms. Dr. Smita, you've been to my home. This is the living room of my home, where these objects are hanging in free space, and the collaborator is right there as an avatar. And so we have now been using this regularly in our CAT meetings. We hold our meetings here where we discuss these cases. Students come into this room all the time, from MBBS students trying to understand anatomy to pediatric PGs to, of course, pediatric cardiology fellows who come in and try to have an immersive interaction with cardiovascular anatomy to understand these things much, much better. So there's a big change. Immersive 3D technologies, particularly extended reality, are today in a position to transform medicine and healthcare, and they can have powerful, impactful applications in pediatric cardiac care. And I think these technologies will help making us better doctors, and we'll be able to take even better care of our patients. Thank you.
Mahesh, that was really brilliant. Brilliant presentation. Hearty congratulations for doing such a pioneering work. And in fact, when you started it, I just came to my memory the whole museum of Dr. Richard Van Pra. I'm sure you have heard about him. And
yes,
I had a fortune, great fortune to be trained by him. And each specimen was, like what you have made a 3D printer. In the same way, he has kept all the specimens. Most wonderful person to work with, and so meticulous. And that meticulous dedication is the one which is required to understand the anatomy and the whole thing that you're doing. And you spoke about the tunnel. The first aortoventricular tunnel was closed by the Evenol plague by Lilly High in Minnesota. And Kurt Amplatz was in that team of first aortoventricular tunnel being closed. And the next, when I closed the aortoventricular tunnel with the device, Kurt Amplatz sent me 3 devices. So I tried one, came out, because, the extra cardiac portion is difficult to make out either with the echo or even angio. Measurements cannot be accurate like how you have shown. And ultimately, I succeeded in closing that with the 16 by 14 PDA device in a shunt. So I have closed aortoventricular, aortoatrial, aorto right ventricular, all tunnels. But these tunnels, are difficult to make out on the echo. But however, for me, where the 3D printer is not there, 4D echo is excellent. Of course, but we can't make out the pulmonary tree and other things. But intracardiac structures, whether it is from the RA side or a LA side or RV side or LV side or from above or below, we can see the 4D very well. I think where the 3D is not there, the 4D echo can be used. And one more thing I would like to wish you is, you sent your first patient get the 3D printer to Belgium. Get the specimen from there. So I hope a day will come when the whole world will come to Mahesh and Amrita to get their 3D printer done at your place, so that, the whole world will know that what great brains are there in India. Here, why I'm telling this is, Bob Anderson, He was very proud. You might have met him, and he's so proud of his heritage. But he told me once, Vijay, we have laid the foundation. Now it is left to the you Indians to build the castle. I think you are building the castle, and we are all very proud of you, and a big clap for you.
Thank you very much, ma'am. And technology indeed is a great leveler, and we have great opportunity to do this. Many of the things that we do here are first in the world in the way we are approaching many
Correct.
things. And I think there will come a time, ma'am, when morphology will be so much easier to understand. Like you said, I went to Prague's museum in 2010 and spent few
Yes.
weeks there. It was life-changing for me because I think that's the first time I got a
Absolutely.
morphological perspective on what a DORV is.
Fantastic.
Before that, I did not know. For 6 years as a pediatric cardiologist, I did not truly understand. But that really set me off on a journey on understanding this much better, and came back, started the MR facility here, and then it just went on. And today, with these technologies becoming so available, accessible to us, we are at a point when it is up to us to create newer ways of doing it. And so we can create morphology museums which are indestructible.
Correct.
So each of these digital specimens we are building, I could send it to you on an email. And you could put one of these 30,000 rupee headsets sitting in your drawing room or in your kitchen or in your office, and it will just appear in front of you, and you can do your dissections, and they are timeless and indestructible.
Yeah.
So
Mahesh, I think what you're saying is I can understand. In fact, I'm really happy that you are a pediatric cardiologist first, and then you have become taken into this imaging. Otherwise, when the first permanent pacemaker was implanted, the person who received was an engineer, and he kept on asking about the circuit and everything to the cardiologist. Cardiologist said, no, I don't know anything about the pacemaker. I don't know anything except that I know how to implant it. And that's how the engineer was wondering, how can a doctor, without knowing anything, how he is doing it? But now we have a cardiologist, that too a pediatric cardiologist, who knows all the anatomy and the pathology. And then you are coming out, and this will be a boon to everyone. I think people can send their cases and get the 3D printing from you. And I hope one day it will come that all over the world, they'll start coming to you. Now, please take my words as prophetic, because in 2002, when I showed the PDA closure in Kuala Lumpur, and that time the Japanese were not doing, Chinese were not doing the device closure, and we were doing. And they gave a standing ovation. And then I said, you can send your patients, we'll treat like a royal listing, and we'll send them back after the device closure. People clapped, but now the medical tourism has taken, and I'm sure you'll make a great effort. And by this, hundreds and thousands of children can be benefited with the better quality of intracardiac lipid. Excellent.
Thank you.
So I'm really proud of you, Mahesh. And I know I kept on telling you that I will come one day and I will learn something from you, but I know it is very difficult for me. I actually traveled to UK to attend the Anderson's retirement symposium, and it was basically because I really wanted to see their morphological specimen also. So I made my trip, but unfortunately that time they were shifting this thing specimen to different place. They subsequently actually created a morphological group, and Dr. Andrews, I kept on getting the info. So they were like 3D printing, and they were making some morphological specimen, not the original one. And that is also, you have done everything on this presentation. And I'm really, I don't know what is your opinion about the 4D echo, vis-a-vis what you are doing.
I think everything has their role. So these technologies will, 3D, like ma'am said, 3D printers are not easily available. These technologies, the expertise is not easily available. It will take a long time to penetrate. So we have to use the tools that we have. 3D echo, 4D echo are extremely useful. And we have to use them to the maximum. Again, it is giving you the three-dimensional depth perspective. what we are doing with these immersive technologies is we are stepping up the game by bringing it out to the screen also. Because the only limitation of 3D or 4D echo is that you are watching it on a 2D screen. And again, you are exercising your spatial intelligence. So you who are spatially intelligent will understand it very, very well and very deeply. Somebody with slightly less will understand it slightly lesser, especially when you look at a still image of a 3D object on a screen, it is still 2D. But when you rotate it slightly, when you move it, then you understand it gives you the illusion of 3D. With the immersive 3D, it actually comes out, pops out. So irrespective of whether it is still or it's moving, you can completely see the depth. So that's the advantage. And then as we are going further, as the signal noise ratios also on the echo become better and better, we'll be able to easily transition these beautiful 4D echo images out into this. We are now with Balu, I'm trying to create this way of bringing fetal echoes. Imagine fetal echo is so difficult to sometimes to understand. Imagine if we are able to pick out this tiny little fetal heart and pinch and zoom it and sit and watch it wearing these headsets like zoomed up and rotating it. It will be a game changer. So that's what we are trying to do right now. So these are all processes in evolution, and I think we are all trying to understand our patients.
So another question would be, Mahesh, like surgeons, they are quite senior and like age actually catches up. So how they are able to match with your this demonstration of this virtual reality, and how they are they really benefiting from what they are seeing? They are like coordinating with the information given to them. How, what is about the learning
Smita,
curve?
in fact, the cardiac surgeons will understand this better than our echo reports.
Exactly.
In fact,
it
is like a toy given to the child. They don't require any explanation.
Love
it. So yeah, ma'am, I can imagine. I just
there is a
wanted
mental
to know
block.
how they respond. I mean,
here, Brijesh, he is here in this lab all the time. He'll just come down here, sit down before going in for surgery, even for something as simple as a reduced sternotomy. Because we do CTs for reduced sternotomy. But now the junior surgeon, Balaji, will come here, sit, put on this headset and get under the sternum, exactly understand which structures are touching the sternum.
So literally they are seeing what they have to do. So that's how, it is like a child's play.
Very well prepared. So that's why all the complex cases get discussed in this lab. So that, and then again, one day before the surgery, morning of the surgery, they'll come down, sit here. So our physical printing has now really reduced. Because for the hearts, we are mostly doing it in VR. But for many other specialties like head and neck, etc., we still print a lot. But for hearts, we use print only in very specific cases. But VR is being used, a lot. But obviously, in only the complex. Surgeons just love it, and they are going to come out with papers which will show how many cases and what all the benefits. It's very difficult, of course, to measure outcomes, right? Because there's so many factors that determine outcomes. But the basic premise is that if we as doctors understand anatomy well and we are better prepared, definitely we are, better empowered to do a better job for our patients, from decision making to procedural planning.
But Mahesh, as I told earlier, for me, I started 4D echo, the first one in India.
Yes,
and at that time, it was so beautiful. I thought I was excited like a child when I started seeing. So there was a VST with the pulmonary stenosis. I had kept everything ready for the pulmonary valvoplasty and the VST closure, device closure. But when I did the LV angio, the no dye came. So I came back and did the 4D echo, saw from the RV side and the LV side, the VST was literally closing during the systole. And that's how the dye was not coming. In 2D echo, I had measured it as 4.5. And this was less than 2 millimeter. And it was literally not there during the systole. So that's how we know the 4D is amazing. Especially ventricular rupture, one post MI. On the echo, we had 12 millimeter. But when I looked from the LV side, it was 18 millimeter. When I looked from the RV side, it was 22 millimeters. And then all the friable tissue was there. And this is how our understanding is much better with the 4D echo. I think it is an excellent tool, 4D echo.
Absolutely.
But as I said, the lungs and the pulmonary arteries and collaterals, all that cannot be made out with that. But otherwise, 4D echo is excellent.
That's great.
Totally agree.
So, ma'am, any other comment? Dr. Amit, you want to comment anything? You tell something about this presentation, your comments?
Any questions from the participants or
Really, Dr.
chat
Mahesh,
box?
that was an excellent overview of what excellent work you are doing. And this is really going to help a lot of not only surgeons in the surgical field, but for fellows and even cardiologists of our repute to assess and analyze the heart in a total three-dimensional perspective. I just wanted to know, is there any role of this printing as far as physiology is concerned? Can you can this technology help in the physiological assessment of cardiac lesions?
So that's the next level that we are ideating on. Just like we have 4D flows on MR, visualization. Ultimately, it's all visualization. So we have proposed with some of the engineering people to help develop these things so that we can see blood flows as well through these structures. It's already possible for us to do these VR visualizations in cine mode. Now we want to bring in blood. So it's all a matter of computational, applying computational sciences to this.
Correct.
So the same.
Dr. Mahesh, there is a question for you. There is a question for you. Dr. Mahesh, have you tried the same for neo-LVOT construction before transcatheter MVR?
Not very specifically for LVOT construction before transcatheter MVR per se, but we've used it in multiple structural diseases for the adults, including mitral valve replacements, perivalvular leaks, and also LVOT resections for HOCM. So,
and one more question there, or for the other adult, please read that question. For other adult
and for other adult SSD interventions.
Yes. So on my part, I keep evangelizing and telling others, okay, you have any problem, you come to me, let us discuss. So people come with all kind of problems. So whenever they come with a problem, like the adult cardiologists have come up with problems of, very difficult looking coronary lesions. They've come up with, very difficult looking paravalvular leaks. Simplify the process for them. And people from multiple specialties, not just cardiology, they come from all over the hospital. A needle lost
I'm sure even orthopedic surgeons must be coming to you.
You name it, everything. Neurosurgery, hepatobiliary surgery. Just last week, I was talking at a hepatobiliary conference on using these technologies in resecting difficult HCC and cholangiocarcinomas, about which I have no clue about what a cholangiocarcinoma is, but I can show them exactly what to do and what the spatial relationship of the portal veins and the hepatic veins are with the tumor.
Excellent.
So it is up to us as doctors to discover newer ways of using these technologies. Even basic scientists, I invite them to come here, take a look at a drug structure or the structure of a protein or the DNA, to understand how, like a mutation, how would it alter the protein structure? Even those can be spatially understood much better using these technologies. So it is an open field. And there could be infinite applications, not just one or two, infinite applications.
I know. Excellent.
That's great. So I think we can close now session.
I think both the speakers did excellent work, and I expected more questions from the audience. And I hope, this will be like a stimulation for them to come up with the next questions. And congratulations to both of you. Thank you, Smita.
So, yes,
well
Dr.
soon.
Amit, very comprehensive. I mean, this was a very, very good lecture for all upcoming pediatric cardiologists, neonatologists, and the focus people and the cardiology, adult cardiologists. So, I think if I hope video remains online because the audience seems to be less, but I think they can see later also. That is the advantage of a Zoom meeting. And Dr. Mahesh, it was all virtual world gaming kind of thing. So we were with you in your room for a while and I really loved it. It was really wonderful. And I will talk to you later. I would like to use few of your images in my next lecture. I'm preparing for
Mahesh,
someone.
I was feeling like a child, I was wishing to go back 20, 30 years back,
You have always retained your childlike curiosity, always, ma'am. That's been unchanged.
No, I was so excited.
So I will use few of the, and I will take you, I will attribute to you, if you don't mind, Dr. Mahesh. Online, I'm telling you, and I put your big picture on the that put thing. It is all
Thank,
yours, and we
thank you
are
Thank
very
very
you.
proud
much.
of
Thank
you.
you very much,
Thank you.
every
Thank
one
you,
of you.
Nandita.
Thank
Shubharatri.
you. Thank you,
Thank
Madam.
you. Good night.
Good night.